Now we are going to proceed with the third tutorial case. This is impaired vestibular compensation in the face of vestibular neuritis. The history: a 65-year-old retired man presented with a complaint of 6 months of dizziness and disequilibrium, especially on compliant surfaces such as a plush carpet. Since their onset, his symptoms were characterized by nearly constant imbalance when walking or standing and lightheadedness even when seated. Rapid head movement exacerbated the patient's dizziness, which was associated with blurred vision. He did not complain of recent vertigo or any positional symptoms. Specifically, there were no complaints of dizziness when rolling over in bed. The patient noted no recent change in hearing or any tinnitus or oral fullness. He was essentially asymptomatic when lying still. If he was lying down and still, there was absolutely no symptoms. Now, this patient that is presented to us is a 6 months duration of dizziness and disequilibrium. There are some other characters to this dizziness and disequilibrium, but then here we have 6 months of dizziness and disequilibrium. Disequilibrium is as in imbalance. And this kind of a presentation is one common kind of presentation in our clinics. When we are faced with a person who has a dizziness going on for months together or sometimes years together, we need to have a structure to deal with that patient to reach a diagnosis. Before we seek further points in history, let us first familiarize ourselves with one structure to approach this particular type of patient. A person who comes with long-standing dizziness. We should attempt to place them into one of the three categories based on the origin of the dizziness. Did it start off as a vertigo? Was there a past history of actual vertigo before this actually started? And now he has dizziness and or disequilibrium, that is imbalance. Or there was no vertigo at onset, but the disequilibrium has been progressive. And no vertigo, no disequilibrium or imbalance, just dizzy, all the time dizzy. So, which of these categories does our patient belong to? We need to characterize, and then from there, each of these groups offers a certain kind of differential diagnosis. If there has been a past history of vertigo and now the patient has dizziness and or disequilibrium, then the possibilities that can be happen is a failure of compensation or a maladaptation. So visual vertigo or visual dependence is one such kind of maladaptive behavior that happens where they become too much dependent on vision for giving their posture, giving input about their own self position and self motion. They depend on the walls, vertical lines in the walls, all these things to tell whether they are straight or not. They actually depend on the optic flow pattern that happens when they move forward and backward to actually assess how far, which direction they are moving. So they start becoming too much dependent on the visual input. So they start developing visual vertigo, which means whenever the whole scene moves, they are in front of it. TV screen, they see fast moving objects on the TV screen, they start scrolling the mobile phone and they feel dizzy at that time. They are in the road, a big bus passes in front of them, they feel shaky. They are in the railway station, the train passes in front of them, they start feeling shaky. That kind of a thing can happen in some people. That is visual dependence. The way to test them is you can do a subjective visual vertical test in the face of a dynamic background, on a moving background, and they show a lot of influence of the moving background makes them do errors in placing the vertical line. They show for optokinetic stimulation, okay, they are symptomatically poor in when it comes to tolerating optokinetic stimulation. They start feeling a sensation of circular vection. And then in posturography, there are protocols to test for visual vertigo in the face of optokinetic stimulation. They they shake more. Then they can show something called as, there is other group of patients, or there may be combination of these things. In the face of a past history of vertigo, now the patient is dizzy or equilibrium. One of the possibilities is they have developed a visual vertigo. The other possibility is surface dependence. They can have multiple, not just one, they can have multiple of these things also. Surface dependence is, they start giving too much weightage only to the proprioception. So when they start giving too much weightage only to the proprioception, when the proprioception becomes unreliable, they start becoming shaky. As in this, the person whom we are looking at dealing with is a person whose walking becomes worse on thick cushions, okay, or when the carpet is cushy, these kind of things, the person is having difficulties. That is what has been told to us in the history. Then there is another kind of maladaptation that can happen in these patients is motorist disorientation syndrome. Motorist disorientation syndrome is a condition in which when the patient is driving, they feel that the vehicle is veering to one side, veering to right or veering to left. And that is so much, they are so much convincing, that kind of a sensation, that in the beginning they don't even think there's something wrong with them. They think the vehicle is a problem. They think there is air on one side is less, or the alignment has gone off, something like that. So before they actually meet the doctor, it can so happen that they actually meet the car mechanic before they come to us. I have a patient who has gone to the car mechanic first before coming to the doctor. Then there is persistent postural perceptual dizziness, another maladaptive behavior that can happen after past history of vertigo. We'll deal with a separate case discussion of this one. Then they can have chronic vestibular migraine, and then it can also mean a late stage Meniere's disease. So if you are faced with a patient with dizziness of a long duration, or disequilibrium, or both of a long duration, the first attempt should be to place them in one of these categories. How did it all begin? Did it all begin with vertigo, with spinning vertigo? Now you are dizzy. If that is the case, there are so many differential diagnoses, or the different maladaptive or non-adaptive patterns that the person could have gone into. Then no vertigo at all at onset in the history, but the patient's imbalance has been progressing. The disequilibrium has been worsening without vertigo at onset. In that case, then there are certain differential diagnostic possibility. Bilateral vestibular loss is one such. The way to diagnose a bilateral vestibular loss is with a head impulse test or a caloric test. You can do them instrumental or non-instrumental, but then that is one way in which you diagnose a bilateral vestibular loss. Then we have orthostatic hypotension. Orthostatic hypotension we can diagnose with a proper BP protocol, which we have dealt with before, or a head-up tilt test. Downbeating nystagmus will be revealed in an eye examination with and without fixation. Then normal pressure hydrocephalus or cerebral small vessel disease. Okay, both of them also can be contributor to progressive disequilibrium or imbalance without a preceding vertigo. And MRI helps us in diagnosing cerebellar ataxia. So we need to do a cerebellar workup for cerebellar ataxia. We will deal with what exactly constitutes a reasonably exhaustive cerebellar workup. Then there is polyneuropathy. We can do a vibration assessment test with 128 hertz tuning fork. We can do an EMG, and we can do biochemical tests like vitamin B12 assessment. And then Parkinsonism, which needs again thorough neurological examination to pick up the findings, especially in the early stages. So what actually constitutes a cerebellar workup? When we say a cerebellar workup, the good news about what is a cerebellar workup is there are some really easily treatable causes. One of them is alcohol history. Okay, of course we need to do an MRI to see if there are any atrophies or any abnormalities with the CV junction. Then B12 level, vitamin E, B1, then test for inflammatory markers and paraneoplastic markers, and sometimes even genetic testing depending on what other findings are there. Then we have the Third category of patients, the person tells I am dizzy. You try to ask them, do you feel any spinning sensation? Was there any history of any spinning sensation before? No, there is nothing like that. Then no disequilibrium or no imbalance means the person feels dizzy, but then walking itself is quite good. Your postural test, Romberg test, all of those things are actually good. Okay, so no disequilibrium or no imbalance, or no actual vertigo, but the patient tells all the time dizzy, dizzy, dizzy. This is another category of patients that we see. And in that, some of the diagnoses that are to be considered are anemia, hypothyroidism, drug toxicity, diabetes, even orthostatic hypotension, and psychological causes. So, just to reiterate, whenever we are faced with a patient of this kind of a patient of a for months together or for years together of dizziness or disequilibrium, we first try to put them in one of the three categories. Has there been a past history of vertigo, and now the patient has been having disequilibrium? No vertigo at onset at all, only progressive disequilibrium. Okay, and then no vertigo, no disequilibrium or no imbalance. All the tests turn out to be really good postural tests. The gait seems to be good. Patient actually does well on some of these tests of balance. Patient is only feeling dizzy. Then what are the set of differential diagnoses? With a past history of vertigo, we have to look at lot of non-adaptive, maladaptive, or failure of compensation or maladaptive compensation that develops in these patients. So these are the differential diagnoses that can be contributing to the patient's symptoms. Okay, there can be surface dependence, visual vertigo, motoris disorientation, persistent postural perceptual dizziness. Chronic vestibular migraine is one thing to be kept in mind, where in the beginning the patient has had episodic episodes of vertigo, headache, these things, or with or without headache, only vertigo, some of the patients do show. But now the patient has become more chronically imbalanced. So in the past history of vertigo, these are all the differential diagnoses, including late stage miniaris, where the history itself will tell us the diagnosis. And if there has been a progressive disequilibrium, sometimes not progressive, especially in orthostatic hypotension, it may not really be progressive, but this is without the patient does not have a past history of rotatory vertigo. The past patient did not have any attack of vertigo, and a patient is presently facing these things. Then we have dizzy but no vertigo, no disequilibrium, and then here also orthostatic hypotension can find a place, but then there are other differential diagnoses also to see. And finally, if most of the workup, this needs a careful examination, careful workup, and after that you find nothing, and then if there are positive features for psychological, then you do consider psychological aspects in this group of patients. So further history based on all this approach, a further history of this patient, when we see, we will know what exactly this patient is going through. The patient dated his symptoms to an acute episode of vertigo associated with nausea, vomiting, severe disequilibrium, lasting for several hours 6 months before the evaluation. So basically, with this particular additional point in history, we know where we are placing this patient. We are placing this patient in the first category, now having dizziness or disequilibrium, but previously began with the vertigo. So he had not complained of dizziness before that episode. He was evaluated by his primary care physician and was believed to have a peripheral vestibular ailment. The patient was treated with meclizine 25 milligrams orally 3 times daily. This provided some relief but was minimally successful in alleviating his symptoms. The patient had to decrease his activity level to such a degree that he no longer drove an automobile or took his morning walk and discontinued gardening. Despite these changes in his activity, he continued to experience daily dizziness, and his physician increased the dosage of his meclizine to 25 milligram 4 times daily. Other than dizziness, the patient had no significant medical history. The family history was non-contributory. So we know what has been done to this patient, what the patient had. So it began with a vertigo, and we know what is likely to be that vertigo due to, and how he has been treated. So what we are seeing is he's reduced his activity to a extent that he is no longer drove an automobile. These are not adaptations. These are maladaptations, and we need to use this terminology to tell the patient that this is not adaptation, this is maladaptation, and that has to change for them to improve. So based on the patient's history, what is the most likely diagnosis and why is the patient experiencing dizziness? The patient's most likely diagnosis is vestibular neuritis. What the patient had, the primary problem, what caused dizziness 6 months ago, what caused vertigo 6 months ago, is actually vestibular neuritis. Acute vertigo, which was unaccompanied by hearing loss, tinnitus, and oral fullness, is unlikely to be caused by Meniere's disease. Other possibilities include an ischemic insult to the vestibular labyrinth or nerve or some other non-specific vestibulopathy, but at the end of it, it is related to the labyrinth or the nerve. In any case, the patient's history is consistent with an acute peripheral vestibular ailment 6 months before evaluation. This is what happened. There has been a vestibular ailment, acute peripheral vestibular ailment. But what is leading to the person's persistent dizziness? The patient's persistent dizziness suggests that he has not compensated for his presumed peripheral vestibular loss. Usually, compensation requires several days or weeks. This patient's continued symptoms suggest impaired compensation. His continued symptoms of instability during standing and walking suggest an ongoing vestibulo-spinal abnormality. The patient's blurred vision immediately following head movement suggests a vestibulo-ocular abnormality. So he has two abnormalities which have not got set right, which has not 6 months down the line have not become good, vestibulospinal and vestibulo-ocular. And there are clear-cut symptoms attributable to the vestibulospinal pathways and to the vestibulo-ocular pathways. Meclizine does not appear to be a successful treatment. Possibly this medication is actually worsening the patient's symptoms by suppressing needed vestibular input, and the medicine itself is interfering with the vestibular compensation. The physical examination in this particular patient. General examination revealed an elderly appearing man who made minimal spontaneous head movement. So he was trying to hold the head rigid. Neurologic examination revealed a few beats of right beating nystagmus on right lateral gaze that were unsustained. Otherwise, the patient's cranial nerve examination was normal. There were no changes in strength or sensation. There was no incoordination. The patient's gait was slow with a short stride length. This is what the patient has become cautious. So the stride length has become shorter and he started walking slowly. So this is a behavior of caution. His head was held rigidly during walking. The patient could tandem walk only with assistance. Romberg's test was negative. Otologic examination was normal. A low amplitude right beating nystagmus was seen in the primary position when examined with infrared goggles. Without infrared goggles, few right beating nystagmus only on the right lateral gaze, but on removal of fixation when examined with infrared goggles, the right beating nystagmus appeared even in the primary position. The head thrust test was abnormal to the left. So Dick-Salpike maneuvers were negative. The patient could not stand on a compliant foam surface with the eyes open or with eyes closed. Fast pointing was absent. So here there is a very significant pattern of physical examination that is there. The patient could not stand on a compliant foam surface with eyes open or eyes closed. Pure vestibular abnormalities, they start showing symptoms on the foam when the eyes are closed. This particular patient is showing a little bit additional problem, that is, even with the eyes open, as long as the person is on the foam, has to sit on the foam, the person is more unstable. This is what is called as a surface dependency. The patient has given, so people can develop visual dependency or surface dependency as a consequence of one of the peripheral vestibular losses. So here this patient seems to have developed surface dependency, which means as long as the surface is reliable, the person is able to, feels better. But when the surface becomes unreliable, the person suffers. Same happens with visual dependency. As long as the walls are all non-moving, everything is perfect, then they don't have a problem. In fact, it is going to help them, the vision. But if there are moving screens, moving water, moving cloud, wind-swept trees, or a moving train, moving car, moving bus, anything where that movement actually does not represent the person's actual movement, then the person gets confused. Same here when it comes to surface dependency. As long as the floor is all stiff, firm, then it helps them. But when the surface dependent pattern is given a floor which is a cushion, which is soft, then the person actually suffers. He cannot stand well. So what additional information regarding the cause of this patient's dizziness was provided by the physical examination? The patient's examination suggests that he is avoiding vestibular stimulation by severely limiting his head movement. Moreover, the patient's nystagmus, although minimal, suggests an ongoing vestibulocular asymmetry that has still not got completely compensated. Even when the person is not moving his head, the vestibular asymmetry, the nystagmus is persisting, which means that has not been equalized in the level of the brainstem. Complete compensation has not happened. So, the patient's nystagmus, although minimal, suggests an ongoing vestibulocular asymmetry and a vestibular compensation abnormality. It is likely that the patient has not compensated for his presumed peripheral vestibular deficit. One reason for the patient's failure to compensate may be inadequate vestibular stimulation because he limits his head movement so severely. So when this is actually a maladaptation, this patient needs to be encouraged to move around. Instead of increasing the dose of meclizine, it should have been reduced and the person should have been asked to move around more freely. So the investigations of this patient. Video nystagmography. Ocular motor function was normal. A very low amplitude right beating nystagmus was seen with the eyes open in the dark while seated and during positional testing. So this is a low amplitude right beating nystagmus was seen with the eyes open in dark while the patient was seated. And also during positional testing. What should not be confused ever is, if the person already has a nystagmus and that is also observed during positional testing, it is not a positional nystagmus. It is the spontaneous nystagmus that is persisting into the positional test. Therefore, we should always be careful while interpreting positional nystagmus because we should always have a baseline eye examination in the seated position. In the seated position, in the upright position with removal of fixation, if the person did not have any nystagmus and then a new nystagmus appears in the positional test, then it is positional nystagmus. If a pre-existing nystagmus persists into position, it is not a positional nystagmus. This nystagmus increased with rightward gaze. Caloric testing revealed a 50% reduced vestibular response on the left side. Rotational testing revealed responses of normal amplitude and timing. However, there was a right directional preponderance. What does right directional preponderance mean? During the rotational testing, rightward rotations cause right beating nystagmus, leftward rotations cause left beating nystagmus. That is when the rotation is ongoing or at the beginning of the rotation. This particular patient showed a little more right beating nystagmus than left beating nystagmus. Posturography indicated a surface dependence pattern wherein the patient had excessive postural sway whenever he was standing on a sway referenced platform regardless of the visual condition. So, that is on conditions 4, 5 and 6. What does this mean? In the posturography protocol, there are 6 protocols. The protocol 4, 5 and 6 are where the surface on which the patient is standing or the subject is standing, it becomes unreliable. It starts moving around. Okay, and it starts moving with the sway of the patient, which means the way the patient sways, that also starts moving in that direction. So, which means it is not going to be a reliable marker of the patient's position. And there can be vision allowed, there can be vision denied, there can be vision confusing, which means vision moves with the patients. Okay, what the person is looking at also moves with the patient. In spite of any of these visual conditions, the person was having more, not related to visual condition, but related to when the standing surface was no longer reliable. When the standing surface, the person's feet where they were placed, when that surface starts moving around, the person becomes shaky. He was able to maintain his balance only when the support surface was fixed. Vembs were absent on the left. Okay, absent vembs again suggest vestibular neuritis in this particular clinical context. Audiometric testing showed a mild high frequency sensory neural hearing loss that was symmetric in both ears. Word recognition scores were 100% bilaterally. An MRI scan of the brain was normal. So, what additional information does laboratory testing provide in this particular patient? Laboratory testing indicates that the patient had both a left unilateral peripheral vestibular reduction and an ongoing vestibulo-ocular and vestibulospinal asymmetry, both of which we could demonstrate. Moreover, the patient's posturography abnormality suggests that he has become dependent on a rigid surface for maintaining balance. This is surface dependency. So people can become visually dependent, they can become surface dependent, or they can have a combination of both. Taken together, the findings suggest impaired vestibular compensation for a unilateral peripheral vestibular insult, despite the passage of 6 months since the patient's acute vestibular syndrome. So 6 months have passed and still he has not compensated. So there has to be reason for that. So what are the causes of impaired vestibular compensation for peripheral vestibular injury? Which of these causes may be the underlying in this particular patient's as a explanation for this particular patient's persistent symptoms? Vestibular compensation depends upon consistent peripheral vestibular activity, even if reduced or only from one labyrinth, means consistent peripheral vestibular activity. Unchanging, consistent peripheral vestibular activity in combination with other sensory inputs such as from vision and somatosensation and normal function of the central vestibular structures. So the central vestibular structure should be normally functioning. There has to be some good sensory inputs from vision and somatosensation, and the peripheral vestibular activity has to be consistent. It should not be fluctuant peripheral vestibular activity. In fluctuant disorders, as in Meniere's disease, it cannot happen. There can be something else fluctuant also in some patients which stops their compensation, that is an ongoing untreated benign paroxysmal positional vertigo. An ongoing untreated BPPV in a patient who has previously suffered vestibular neuritis also can take a long time or will not compensate over a long time. Thus, failure to compensate for a peripheral vestibular lesion can be based on fluctuating or aberrant peripheral vestibular activity. Fluctuating peripheral vestibular activity also will not lead to compensation, as in Meniere's disease, or an aberrant peripheral vestibular activity like a benign paroxysmal positional vertigo. Coexisting BPPV in the same patient will also lead to absence of compensation. I have a patient who did not compensate for months together. Underlying BPPV was there, previous vestibular insult, vestibular neuritis was there. After treating for BPPV, the person started compensating very fast. So, failure to compensate for a peripheral vestibular lesion can be based on fluctuating or aberrant peripheral vestibular activity, a central nervous system abnormality that impairs vestibular compensation, clinical or subclinical involvement of the contralateral ear, multiple sensory deficits, or a sedentary lifestyle. Impaired vestibular compensation can be a result of both structural abnormalities of the brain and dysfunction caused by certain drugs such as benzodiazepines. The patient's failure to compensate for a peripheral vestibular lesion, this patient, is probably the result of a combination of a sedentary lifestyle and medication with vestibular suppression that together caused inadequate vestibular stimulation and impaired vestibular compensation. So this particular patient, one was drugs, the other was is refusal to move, the sedentary lifestyle. Both of them together have worsened the patient. The absence of vertigo and the constancy of symptoms do not suggest fluctuating or aberrant vestibular input from the involved ear. So it is unlikely the patient has any mini ears, or unlikely the person has any BPPV, which need to be looked for and has been looked for in this patient in the examination. It is not there, although this cannot be ruled out entirely. Also, there is nothing to suggest abnormalities in other symptoms, because most of the neurological examination and the investigations was all normal. So the causes of impaired compensation are a fluctuating vestibular function, aberrant vestibular function. We have given example one for each. Subclinical involvement of the contralateral labyrinth, central nervous system abnormalities. There can be structural deficits both in the CNS or elsewhere in the body, like there can be musculoskeletal issues, there can be limb length disparity, one side pain. Okay, each of those things can cause problems. Medication induced, sedentary lifestyle, or fear induced restriction of head movement, multisensory impairment, visual dysfunction, somatosensory dysfunction. All of these things can be the cause. So we need to inquire into that particular patient, every patient, what exactly could be leading to that particular patient's failure to compensate. So when you have a patient who has who's been dizzy for a long time, who has a disequilibrium or dizziness for a long time, and when you actually dig out the history, and then the history tells that it all began with vertigo. But now the patient is dizzy or has disequilibrium. Then we know there are a certain set of conditions that the person can be going through: visual vertigo, it can be surface dependency, it can be triple PD, it can be motorized disorientation syndrome. A lot of things can be happening, but why exactly that has that maladaptive behavior, or why exactly the person has refused to compensate? Okay, why is the nystagmus persisting, at least in rest? Okay, why is the nystagmus persisting for a long time in the primary position or in one eccentric position? Even static nystagmus should be suppressed by good compensation. Why is it persisting? So when we see all these things, then we need to inquire into what could be leading to this in this particular patient. It can simply be one untreated BPPV in the same patient, that is aberrant vestibular stimulation. It can simply mean some drugs. It can simply mean patient's maladaptive refusal to move or holding the head straight. So when we evaluate that, and then when we start treating that underlying contributing cause for impaired compensation, then the patient can be expected to start making an improvement. So what is the diagnosis or differential diagnosis in this particular patient? This patient's history, physical examination, laboratory studies suggest left-sided vestibular neuritis and impaired compensation. That is, the patient has failed to undergo normal vestibular compensation for his peripheral vestibular ailment. The treatment or management: the patient was treated by gradually discontinuing meclizine over 1 week. Additionally, the patient was scheduled for a course of vestibular rehabilitation in the hope of potentiating compensation for his peripheral vestibular deficit. Vestibular rehabilitation was recommended with the intent of reducing the patient symptoms of dizziness and blurred vision during fast head movements. Another intent was to improve his balance by expediting vestibular compensation and reduce his dependence upon somatosensation, that is, to eliminate his surface dependence. Summary: a 65-year-old man presented with a history of an episode of acute vertigo, nausea, and vomiting 6 months prior to evaluation. The patient's symptoms evolved into constant disequilibrium. Physical examination suggested an ongoing vestibular imbalance. This was confirmed by laboratory testing, which indicated a reduced vestibular response and both vestibulo-ocular and vestibulospinal abnormalities. The patient was believed to have a peripheral vestibular ailment with poor compensation centrally. His vestibular suppressant medication was discontinued, and he was enrolled in a course of vestibular rehabilitation. The teaching points of this case are: persistent dizziness that continues for weeks or months following an acute peripheral vestibular ailment may be the result of impaired vestibular compensation. Typical symptoms of impaired compensation include instability during standing and walking and blurred vision associated with quick head movements. Patients with impaired vestibular compensation for a peripheral vestibular injury often avoid vestibular stimulation by severely limiting head movements. Gait is often slow with a short stride length, and the head is held rigidly during walking and turning, although limiting head movements reduces vestibular stimulation and thus the sensation of dizziness. It helps them to adapt to reduce the vestibular stimulation and to reduce the sense of dizziness. But this adaptation is not actually good adaptation. This is a maladaptation. This strategy is maladaptive because vestibular stimulation is necessary to stimulate the process of vestibular compensation. Failure to compensate for a peripheral vestibular lesion can be the result of one or more factors. These include fluctuating or aberrant peripheral vestibular activity, a central nervous system abnormality, clinical or subclinical involvement of the contralateral ear, the presence of other sensory deficits, especially involving vision and somatosensation, or a sedentary lifestyle, or even if the lifestyle is not sedentary, a refusal to do the normal head movement. Central nervous system abnormalities that impair vestibular compensation include both structural abnormalities and dysfunction caused by certain drugs such as benzodiazepines. Vestibular laboratory test results that are consistent with impaired vestibular compensation include the presence of a spontaneous nystagmus, directional preponderance on rotational testing, and abnormal platform posturography testing. Treatment of patients with impaired vestibular compensation includes tapering and stopping the vestibular suppressant medications and instituting a course of vestibular rehabilitation in which the outcomes can appear magical. With that, just to summarize again, we saw the patient who came with a long-standing history of dizziness/disequilibrium. We made an attempt to put the patient in one of the three categories: a disequilibrium now, but previous history of vertigo; only disequilibrium that has been progressing without previous history of vertigo; no disequilibrium, no vertigo, but only dizziness. So one of the three categories, and then in each of the three categories we had a reference of where to look for, what are the diagnostic things to look for. And in this particular patient, we saw that this particular patient has not compensated well, and there, in this particular patient, the absence of compensation of the asymmetry, in addition to that, the patient has also developed a surface dependence. And then we followed up in this particular patient, the reason for failure to compensate was also inquired into, and in this patient it was not aberrant activity like BPPV, it was not fluctuant activity, it was not a subclinical affection of another ear, it is not a central nervous system abnormality. In this particular patient, the lack of compensation was because of refusal to move the head, and second thing is because of the drug. So the treatment constituted removal of that offending drug which was impairing the compensatory process, and the next one was vestibular rehabilitation therapy. Thank you all.